The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. As fate would have it, this is the first episode of the 7th year. Who'd have thought that? And we're very thrilled to welcome Anna Ermarth this week, who is here to talk about celiac disease, which is a very, for me still, kind of mysterious process. And she is going to do a fabulous job of making it very easy for us to understand. Welcome, Anna.
Thanks for having me.
So you're a Texan originally, right?
I am. I grew up in the area of Friday Night Lights, so if anyone has seen that show or knows that book, that's kind of where I originate from.
Yeah, I actually rewatched the pilot episode of that just this week.
Yeah. Well, it is true what they show out there. There's not a lot to look at, but there's a lot of football and there's a lot of dust. So I think it's where I had my formative years. And then I always joke that I grew up in West Texas, did undergrad in East Texas, medical school in South Texas, and said I'm out.
So North Texas had nothing to hold you there?
Yeah, unfortunately, Dallas-Fort Worth, well, I grew up playing soccer and we'd have to drive 3.5 hours just to get into our soccer leagues there in North Texas. So technically I've spent a lot of time there too. So it's a large state, but I love being from Texas. Everyone says you can't leave that. It's with you for your lifetime.
Sure.
But now I've been in Utah for 14 years.
So you came here for residency and fellowship?
Correct. Yep. Fourth fellow to come out of our GI fellowship. And as fate would have it, I've stayed on and long enough to beat the director of that as well.
Fate and our general good luck. Thanks for being here. Thanks for seeing my patients, and thanks for coming on the podcast. Well, I suppose we should start as we always do. Do you have any things that you need to disclose?
Not yet.
You hope for some?
Working on it.
Any skeletons in your closet you want to talk about? Also not.
No.
Okay. All right. Let's dive right in. Let's talk a little bit. First of all, what is gluten?
Yeah, so gluten is that mysterious part of the wheat, and wheat has many components. It's actually a pretty complex plant, which I think is interesting too. We take that for granted, but gluten is the storage portion of the wheat, so the endosperm, and you've got the part of the wheats that are soluble, meaning they dissolve pretty easily when we eat them, and then the non-soluble portions, and that's kind of the fiber and the bran that we have. But the gluten is really where it holds that storage for the next season. So when you replant wheat, the way it works is that the seed of the wheat holds on to that gluten until we can plant it again, and then it grows back. But it's hard to break down from a gut perspective because it's a protein. But the reason why we like it is because when you stretch it out and you manipulate it a little bit with a little bit of yeast, it makes our bread nice and gummy or stretchy and easier to digest that way.
I mean, for people who aren't gluten sensitive, it's part of the satisfaction of eating something made
Totally.
Yeah.
I mean, I've never met a croissant I don't like.
Well, I made pizza this week and, used a balance of flours that would actually enhance the gluten in the dough.
Yeah, so it really makes it satisfying. But then again, like I said, it's harder for us to break down on the end part.
So for people who are gluten sensitive, what is it that's happening that makes the gluten offensive to their body?
Well, it still takes an enzyme. So just like your pancreas puts out fluid for us to break down proteins, our body also has other enzymes that break down more specific proteins. And this is just one of them that is very specific. Humans, I think, were meant to eat wheat, but sometimes it can be too much of a good thing. And then our body sort of rebels against that.
A lot of times things get lumped together, and people often refer even to lactose intolerances that I'm allergic to milk. How is this different from being allergic to wheat?
Yeah, there's a couple things that make my skin crawl with celiac disease. Number one, that's putting an S on the end of the word. It's not celiacs, it's celiac. Just leave it there.
So there is a celiac who described this.
Exactly. And then the second is calling it an allergy. And I think in some ways that demeans it a little bit in the lay people's experience. Everybody kind of calls something they're sensitive to an allergy, but if you truly don't have that, it kind of demeans what the actual medical process is. So for gluten, it's not an allergy. Allergies are, involve those quick acting cells like the IgE and mast cells that really attack something as the first force, the Marines that go out there. The gluten reaction our body does by breaking that down at the enzymes, that's like a third line sort of scenario. And it takes some time for your body to sort of build inflammation to it. So it's a much longer inflammatory process than something like an allergy.
So, how does it cause damage? Clearly, that must be part of the reason why the damage isn't localized.
Right. And it's an interesting thing to me that as a gastroenterologist, we are the experts in it because truthfully, the damage to the gut is probably the last end damage. It's sort of the end of the road because the antibodies circle around in our system for quite a long time before that damage really gets to the gut. And so what happens is that, you have inflammatory cells that sort of work their way into the villi or those little projections that suck all the good food and nutrients out of our food into our bodies. But when they're kind of overworked with inflammation, they cut themselves off, meaning they sort of die at the ends and then they flatten. And so when those villi flatten, there's no way for us to kind of make those biochemical reactions to absorb our food. So that's what happens. That's why it becomes like a slick gut. It just sort of wears down the top of our gut surface.
So, the exposure happens at the level of the gut, but the damage is happening systemically.
Exactly. And the end of the road, like I said, is the gut. But of course, you can see them and you can see celiac present in a variety of ways because of this. So when you've got something circulating in your blood, you can't keep those antibodies from reaching your brain, reaching your kidneys, reaching, all these other areas like the other mucosal areas like your teeth. So some children really present and that's where this becomes sneaky as a pediatrician because you don't just see diarrhea, you might see fatigue or a little bit of slower weight gain or something else going on.
And for the other specialty that owns this disease, the dermatologists have the luxury of being able to see it on the outside of the body.
Yeah, and that is usually the other pathway that gets to us. Although I will say most of the time in pediatrics, when I see this on the GI end, it's slowing growth. And so I think as pediatricians, we're a little bit more in tune to that. Sometimes the rashes can even be sneaky, right? We live in Utah. I think our humidity today is down near 20%. And so everyone has eczema here, and dermatitis herpetiformis can actually present sort of like a eczema look. And so that even is a sneaky presentation. So when you're thinking about ways to catch celiac disease, sometimes you just got to look at that whole presentation because it can be a little more sneaky.
And an actor you're not likely to find unless you go looking for it.
Right. But any rash on the elbow or the knee that doesn't really respond to a first line topical steroid, that deserves a little more, investigation for most children.
Sure. How prevalent is celiac disease? Do we know?
So celiac has been mostly studied in our North American and European descent populations. Europe is great at studying celiac disease. Now North America is great at studying it. So it's a little understudied, I'd say, in Latin America, South America, and Africa. And there is a difference in prevalence. So what we know from our very good population-based studies in Europe and North America is that it's about a 1 to 2% prevalence. Some places are going to be higher depending on their genetic makeup, and some hang out right around that 1%. Here in Utah, we did our population-based cohort back in the early 2010s, and we really found slightly higher in our pediatric group of a 1.7. So almost 2 out of every 100 kids actually have celiac disease. In Sweden, they did a study for the millennial generation and found it higher to be close to 3%. But again, you're talking about a smaller population and a much more genetically kind of contained population. So anywhere from 1 to 3% in the white Caucasian groups. In the Latino ethnicity, that's down below 0.5% per 100 people or less than 1 per 100. So yes, there is some variance according to that.
But at those sorts of numbers in my population, I'm probably underdiagnosing it or not necessarily diagnosing it in a very timely way.
Yeah, and the most interesting piece of this for me that has come out in the last decade. So there's a Canadian group just north of Utah in Alberta, Calgary, and they have really shown through their population cohort, because again, Canada, a little more easier to get things on the same EMR record keeping there. they've showed an increasing incidence over time of the last 20 years, despite testing remaining the same. So I think we're still finding out that we might edge this disease closer to a 2% level that we used to think was closer to a 1% level. So those studies have been done since 2020. And again, some of this is because more access to testing, right? So we have a really good blood test that catches this. And that's where most of these studies are headed, where we're looking at the prevalence of the serology-based diagnosis versus the endoscopic, or the people who have had biopsies for their diagnosis.
So we've talked about epidemiology. Tell me about heritability. How do I see this clustering? And are there special populations I should be concerned about?
So like many autoimmune diseases, females are always going to be a little higher risk. So you're going to see it in females more than males, even in the pediatric population. And then if you have a first degree relative with it, that is a higher chance, almost a five-fold risk. So we definitely encourage families, if they have one sibling or one child with this, to have all the siblings tested at least once. So that's a five-fold risk. And then if you've got a condition that's a more genetically altered condition, and that's being Down syndrome, Turner syndrome, and type 1 diabetes, your risk goes up to about a 10 to 15-fold risk of having celiac disease in your lifetime. And I should mention, that's a difference in celiac disease than a lot of other autoimmune disorders where it's a solid lifetime risk. There are many autoimmune disorders that don't come up until the early 20s or even into the 30s for women, especially things like systemic sclerosis is higher than, even JIA kind of doesn't start early in life. Celiac disease has two major diagnostic points, and that's the 0 to 10 age group, and then closer to 60 years old.
And how about the timing? At what point? So if we're talking about doing blood tests, at what point, either in the disease process or in age, do we expect somebody to become positive?
Usually under 3 years, you're not going to see as high of positivity. And the belief on that, or the hypothesis for us, is that you're just not quite have enough gluten exposure under 3 years of age. I mean, again, like I mentioned, this is a process that takes exposure over time to really create a body response or an antibody to build towards gluten. So under 3 years, you're not going to see it quite as much. That being said, under 3 years is actually usually a more severe presentation. Things that we think classically of celiac disease, like diarrhea, bloating to the point of, looking like the kid has got a basketball in their stomach, and having the other effects of that, meaning a malabsorptive process like a low albumin, and really having both macronutrient and micronutrient deficiencies. So that's the group that, even though you don't see it as often and you don't need to quite worry about every 3-year-old, testing them for celiac, when they do present, they're a much more severe presentation.
It would also seem to suggest that a single negative test is not definitive over
Correct.
time.
Yeah, and so you do have someone that has negative. So when siblings of someone with celiac disease are tested, they might be negative. And we don't need to retest them every year, but I tell the parents, have a low threshold, right? So if you know of one person in your family has celiac disease and the next kid starts to complain of something a little bit like feeling tired after school or not keeping up with their work, have a low threshold to retest, because that chance, like I said, is going to follow them through their lifetime.
And rescreening populations, special populations, Down syndrome, Turner's, type 1 diabetes, we should have a strategy for that.
Yeah, and there are, those are nice national guidelines for all those conditions to test on a yearly basis. And, I think the type 1 diabetes population, they definitely have other symptoms similar, with their diabetes, whether that's stomach aches that come from having a high glucose or a HO1AC that might be out of control. So for that reason, we recommend testing yearly because they're such high risk. And for the Down syndrome patients, same idea, like they may not be able to totally verbalize what their symptoms are. Some are great at it, some are less so. And so it really just makes sense that as much as possible, meaning yearly or at every other year, we screen for them just in case.
So are there environmental changes or pressures that change the risk for celiac disease?
There are, and that's another good thing to point out, that an autoimmune disorder usually needs, well, it doesn't usually, it always needs a genetic component. So you sort of have to have your genetics set up. And then we think that something environmentally sort of changes your cells or kind of tips off your cells that react against some sort of offending agent. And in this case, it's gluten, right? So what we've seen with some of these better population studies come out is that they seem to be centered around metropolitan areas, so more of an urban place. And then there's even a couple studies, one out of the UK with they took 22 million patients and really showed their AI disease burden there. And that was around zip codes that were lower socioeconomic deprivation, which is kind of a fancy way to just say they had higher income in those areas. And so that to us kind of also cues something that maybe there's a difference in how those people live in those areas. Nothing has been teased out directly as causal, but I think we can all agree that maybe there's less intergenerational living in some of that high urban area. You kind of stick to yourself in a 1 to 4 person house or apartment versus maybe a larger household with 8 to 6 to 8 people. And then even Dr. Deneau of my group, he did an inflammatory bowel disease study and showed similar things with inflammatory bowel disease coming up in these higher metropolitan areas. So yes, there is some environmental factors. It's hard to pin that down. The other one that's really been hot off the press this year, the TEDdy group, and this group studies between Germany, Sweden, Finland, and the US, and they've been able to pool their patient populations. They showed just this last year that there seems to be a seasonality to patients with celiac disease, meaning the ones born in the spring seem to have higher risk. And the way they showed this was these are the patients with type 1 diabetes. So we know it's the genetic setup for celiac disease. So they were really able to narrow down the genetics of the disease and show that there's actually certain homozygous haplotypes that also seem to be affected. And if you're born in the spring, you might have a higher chance of celiac disease. The rest of that is unknown, meaning why that group? Well, when you think about how old they are when they hit 4 months, 5 months, 6 months, that's right, usually during respiratory season, or August and September when enterovirus seems to sort of spike. So there could be these associations where if in your early years you obtain a virus or something kind of triggers your cells that then later on make them want to react against gluten. The other hypothesis that have come up out of Sweden is that, they had a higher percentage of patients born in the late 80s, early 90s. So really the crux of the millennial population. And they seem to have that higher prevalence. And there's thought that a lot of families were introducing solids earlier and maybe a little bit of an earlier introduction of wheat and gluten products in the infant years for that. So I think these are super interesting. It'd be great to kind of really hammer down one risk or another. But at the same time, I think viruses to a baby can be helpful and teach our immune system a lot about how to react. So I wouldn't say avoiding, getting pregnant and having a kid in the spring is worth it, but something, that we kind of think about.
Any association with antibiotic use?
Yeah, and so similarly, there's the European studies have shown that possibly antibiotic use or at least exposure in that first year and dose exposure has been shown, meaning the more antibiotics, maybe the higher risk of celiac. Again, this would be interesting because, as you know, sometimes, we can't fully appreciate if the ear infection is from a virus or a bacteria. So is it the virus or the antibiotic? We're not real sure.
So in approaching this problem, I guess what you're suggesting is that there's sometimes that it's quite obvious when we should be thinking about celiac disease, and other times when we should be thinking in terms of associations. And it's as much as anything a matter of keeping your eyes and mind open.
Yeah, and I think for pediatrics, especially, everyone likens us to veterinarians, right? We really have to use clues rather than how our patients accurately describe something. And so when someone presents to you and there isn't that genetic component, meaning we don't have a condition associated and we don't have a first degree family member, I often say just remain curious, Now, do I want to test everyone that comes in with an abdominal pain complaint for celiac disease? No. But there is some level of suspicion, if the child just seems to be sleeping longer, or maybe they do have a slight anemia when you do some preliminary blood work. So there can be a lot of clues. And that's again where, as pediatricians, we do have a lower threshold sometimes to do blood work, but I think that's okay because it's hard for patients to tell us. And then I worry that, sometimes if you have these antibodies early in your blood, yes, it affects the gut, but affects so many other things. And so I really encourage, pediatricians just to think outside the box sometimes before the child has diarrhea or weight loss or something more obvious.
Any thoughts on supporting the notion that preverbal children should come with closed captions?
Totally. I mean, if I knew everything my toddler was thinking, I'd be writing popular books by now.
Or, or very inconvenienced. One final question on this section. What about the whole tendency of people to go on gluten elimination diet without any serologic or biopsy evidence?
I applaud you for bringing up the controversial pieces early in this set of discussions. So that does make me cringe a little bit, right? We'll get into this with our testing, but you really can't test for celiac disease if you're off gluten. Now, should you be off wheat because you think the products of wheat are somewhat, sensitive or pesky to our system? Sure, but I would say if you're thinking gluten or celiac disease, don't take your patients off gluten. Can you do wheat light? I'm not opposed to that. And I think if you're in a low risk family, I have no opposition to changing that diet, but gluten elimination diets as sort of a test factor, I'd say that's really unnecessary. Again, when we talked about the prevalence, we're talking about 1, maybe up to 3 per 100 people in our area that have this. And that's still not high enough to say that we have to change, our whole lifestyle just to find out if we have disease.
I think you're going to suggest in a couple of weeks that the whole notion of going off gluten is not for the faint of heart.
Right. No, it's a total lifestyle change and the way you spend your money. So exactly. I think if somebody, is really worried about this, talking about it with their pediatrician, talking about it with their healthcare provider is the first step before you just go and change your whole dynamic of the household.
I'm at risk of opening a can of worms here at the very end of this episode, but are there other things that can make your body object to gluten besides the IgA celiac disease response? You hear a lot about people saying, well, I think I've got a gluten thing, but it's not celiac disease.
Yes. And so to go back how wheat is made or the genetics of wheat, it's not just the gluten, right? Like I said, you've got bran husk in there. You've got the soluble portions that maybe just depending on how much acid you created that day, it's easy to digest or not. So there are other components of wheat that could be causing similar symptoms of just indigestion, a little bit of bloating. I think we all think we're doing ourselves a favor by eating a Fiber One bar, and then you feel terrible after you overload on those. And you look at the ingredients, and it's nothing but just overload of fiber. So you really have to be careful of how you feel when you take out wheat. And then again, we'll get into this later, but there's a huge placebo effect with that too. Or maybe not a placebo effect, but now people are paying attention. And once you're paying attention, you could have a lot of different responses, whether it's better or worse. So I just find there's danger in taking all of the gluten out of a diet without a true diagnosis of celiac disease.
And in an era where we can learn a lot about the underlying cause, maybe it's better that we do a little investigation. And we'll talk about that next week.
All right. Looking forward to it.
All right. Thanks, Anna. Appreciate your expertise. For those of you who have questions, please send your questions. And I'm sure you do, by the way. Please send your questions to questions@vcurb.com, and we'll talk about those in a couple of weeks. Dr. Ermarth, any interest in coming back next week?
Oh, I'd love to get more into this. We have more to tell.
Yeah, let's talk about diagnosis next week. Thanks for your time, and we'll talk again next week. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Wirkus, who also composed the theme music. See you next time.